you so much, John. So I am delighted to introduce Dr. Alysse Wurcel, who is kicking off this year's meetings. I don't think we could have made a better choice. Alysse is a colleague of mine in medicine and infectious disease at Tufts. She is an associate professor in the School of Medicine, and she is a fellow of the Infectious Disease Society. She joined CIMAR in 2021. And her research portfolio focuses on examining health disparities in populations, including people with HIV, people who use drugs, and people who are in the incarcerated setting. And since 2020, Dr. Wurcel served as an ID consultant in the Massachusetts Sheriff Associations, which means the people who run jails in particular, as opposed to prisons. And she's a national expert on infectious disease care in jails. So welcome, Alysse, and I can't wait to see you. And we would like to give you this little gift, which is a CIMAR fleece, and hope that you'll wear it.
Thank you so much. Thank you. Okay, hopefully that's worked. Oh yeah. I'm a loud person. I've always been a loud person. So, well, thank you for coming out. I mean, in this day and age, when you can eat in front of a Zoom or even do something else like, the Wordle rather than listen to me, I do appreciate this. I do. And I'm going to try to make it worth your while. I am a huge Spaceballs fan. If you haven't seen Spaceballs, I understand, and I understand it's generational. The thing I will say to you is that I did not know Spaceballs was a parody until my first date with my husband, as like a 32-year-old, actually. So I just thought it was pure genius on its own, which is kind of crazy, right? Like it's all a parody. I also understand that some Spaceballs jokes did not age well, so it's not that I'm, just recognize that it's just always was one of my favorite movies. I also am a big Etsy person, and so the overlap between Etsy and Spaceballs will show itself. So I basically there's a time in this movie where he says, "I am your father's brother's nephew's cousin's small roommate." But as a disclosure to you, part of my salary is paid from the Massachusetts Sheriff Association. I feel like you should know that. So who am I? The objectives of this talk will just tell you a little about who am I, history about jails and prisons healthcare, an introduction to implementation science, some evidence for antimicrobial stewardship, and sort of my plan to fill the gap between evidence and practice. And like, there's this part in Spaceballs where he's eating soup and this alien jumps out of his belly. And I feel that maybe at the beginning of every talk, you may be like, oh, not again. We're gonna talk about people that are poor and minorities. Oh, great. No. And I really wish this little alien actually does a really cool dance after he comes out and people are really excited about it. So like, I hope that I can take you from that misery of thinking about an alien popping out of your chest to the point where you're like, wow, that's a really cool little alien. I wish I can know it. There's also kind of an interesting overplay to think about really resistant bacteria sort of being that alien, but I haven't figured exactly out. So I am a proud Tufts University double jumbo. I went to undergrad, I was a sociology major, and then I received my master's here as well. I am an NIH-funded health disparities researcher. I'm an ID doctor at 5 county jails and at Tufts Medical Center. And I'm a lover of all things Spaceballs. And I believe, a little bit of a lag here. So I believe that inefficient and inequitable systems of healthcare can be changed. And that's where that came up with sound. So when will then be now, soon? And I think a lot of us want to change the inequitable and the inefficient systems of healthcare. And it's hard because it's almost like we have to find time and we have to make room for it in our schedules. I believe they can be changed, and that's what I wanted to devote my life to, is changing inequitable and inefficient, because they go together, systems of healthcare. So if we often as doctors or clinicians talk about health and well-being. We're thinking about the person who comes into the hospital with their MRSA endocarditis, or we're thinking about the person with their wounds. And we think about their health and well-being. We say, well, there are these things, well, they don't have a good education, so we have a hard time explaining to them how to take their antibiotics, or they're poor, so they can't afford the copay, or all these other things. But I'm asking you to think back to the roots of it all, okay? Because the roots are deep. The roots are very, very deep. And some of these things, these poor health outcomes that we see, a lot of the inequities are a result of roots placed very, very long ago. And if we don't look at the roots, we are missing a lot of them. And you may not, the things like roots, like that having infectious diseases appointments between 9 and 5. I'm not saying it's an easy fix. I'm just saying if you have a job that doesn't let you come to see a doctor between 9 and 5, and the person who has that job is more likely to be poor, that's a root. So let's just think about the roots of disparities rather than just focusing on, oh, well, they're poor or they don't have an education or things like that. There are roots. And then the next thing that I'll talk about is 1 in 3 men who are Black, born in 2001, will be incarcerated during their lifetime. Okay. 1 in 17 white. And I'm just going to let that marinate for a second, because we can do logistic regressions and we can look at race, we can look at all these different things. But that is a fact, and that is our society, and that's the way we live right now. Okay, and so there's a lot of reasons. So when I talk about people who are incarcerated, and I talk about people who are in jail, the structural discrimination and things have led us to this. There's no other reason for this difference. Okay, so brief detour to discuss implementation science. So implementation science help us understand how to bridge the gap between what we know and what we practice. For example, we know that hemoglobin A1Cs are a way to help us treat people with diabetes, but maybe the clinics don't do it every 6 months. What are the barriers? Things like that. So to think about, rather than getting scared by this term, you just back out and say, okay, I want to be an implementation scientist because I want to bridge this gap between what we know and what we practice. And I want to bring implementation scientists to help infectious diseases care in jail prisons. The first jail ever in the United States, in Lawrence County, this is a picture of it. And Alysse, thank you for mentioning this. It is important to use the correct terms. I am a jail doctor. I am not a prison doctor. Jail is short incarceration stays, an average actually of 30 days in Massachusetts. And really most people are in and out often very quick. They're run at the county level. There are different healthcare corporations. So about half the jails in Massachusetts are for-profit healthcare corporations, and about half are at the state. People are younger, and people call it the revolving door, which I don't know. It is a little bit of people come in and out, not for fault of the health system. Prisons are a longer incarceration stay. It is federal and state oversight. People are older. There's, at least in Massachusetts, one healthcare corporation across the state. Oh, and I already said older. And just, we have a tiny state in Massachusetts. I'm thinking about doing this in Nevada or thinking about doing this in California. So these are the prisons and these are the jails. And I circled the jails that I go to. So, and I say this because if you see someone or if you're caring for someone as a clinician, it is important to know, was it prison or jail? It is important because that'll help you know where to find the information from. But jails and prisons were not created to deliver health. They weren't. They were created for public safety back, in the 1600s or 1500s. So, and that was to lock people away who were deemed to be potentially aggressive or hurt others. A lot of people who are locked away nowadays had never hurt anyone. They have mental illness, they have drug use disorder. There are some people who did. I'm not going to cherry coat that. There are some people who did. But when you think about why someone goes into jail, it's not often the same reason as you think about why people used to go to jail. And that again has to come related to marijuana laws, related to all these different areas. So a brief history of healthcare in prison. So in 1967, appropriate staffing for prisoners was considered 1 doctor for 500 prisoners, and the prison doctor would only work 8 hours a week. That was This is, if you have interest in it, this is the landmark Supreme Court case called the Stone and Gamble, in which it determined that all prisoners have the constitutional right to adequate health care. In 1971, there was something called the Attica Prison Riot. One of the main grievances that pushed this forward was inadequate health care. And then in 1980s and TB and HIV made people realize the importance of giving high quality, low barrier testing and treatment in jails and prisons. Because the TB and the HIV and what other infections and anything are behind those walls will be out on the bus ride, in the supermarket, if you don't address it. And so it's sad that it had to come across that way, but that's the truth. That's how it came across. Similarly, jails and prisons were not created to facilitate research. And it is worthwhile to read about this. On the left, we have the person who's in jail being infected with malaria purposefully. So you see under that class, there's a mosquito. And a list of, and on the right, retinoic acid was developed in California. The list of treatments that we use, pellagra was syphilis. You know, it doesn't stop at the Tuskegee. If you could walk out of here, just know it didn't stop at Tuskegee. That's only one thing that we actually learned about. Tularemia, and some would argue it's still going on. These unethical practices that built our current day systems of care. In 1978, the DHHS research regulated permitted research, but they limited the FOD, and it was really very limited. It was only about the idea of criminal behavior or institution of prisons, and it basically turned us into this world in which I'm not talking about this. It swung the pendulum too far. And there were a lot of reasons why that happened. I think today we are still working against it. So how do you balance ethical research with someone who doesn't have maybe feel the ability to say yes or no to research? So I'm bringing you to this place to say infections are common in jails and prisons. And there are ones that we think about, like hepatitis A, B, and C, or HIV, or influenza, or syphilis, COVID. I didn't put COVID on here just because I didn't want to have COVID on the slide, but obviously COVID's not in jails. Gonorrhea, chlamydia, TB. I see tons of dental infections. I do not know why people are not talking about dental infections in jails. You have the overlay of poor access to healthcare, oral healthcare. You have the negative effects that potential drugs can have on your mouth. You have so many overlays. And there are just lots of infections in jails. And it's where the ID doctors really find a lot to work on. So epidemics spur reconsideration of research in criminal and viral populations. So that started with tuberculosis and viral hepatitis and HIV. And I remember being in, helping these jails and thinking, oh, this person has COVID and he's going to go to the hospital, but may not be able to get remdesivir because it is a clinical trial and clinical trials are not allowed. So we withhold these things. You are not allowed to be in a clinical trial, or at least if you're in like a clinical trial that's not completely observational. There are these barriers. So hoping that person maybe there's a way that they can get unincarcerated, released before they get hospitalized. So I'm going to bring you to my experience of summer 2021. I identified a gap. I saw an older man with osteomyelitis of the foot. He was on 4 months of Clindamycin when I saw him. By the time I saw him, I will tell you, I saw him recently. He still has that osteomyelitis of the foot. It's not been delivered. Not on antibiotics, but it's still there. And then I saw a young man with dental abscess who's not improving, despite having tons of rounds. Interestingly, I spoke with Param Sundhi this morning and says in Switzerland, they don't use antibiotics. It's just not used. You pull the tooth or you just move on. You just don't use antibiotics. People are on lengthy, you can't get the dentist to come in or whatever. People are on lengthy antibiotics and it's not killing the problem in the prescriptions. So who is monitoring antibiotic prescriptions? And the truth is no one. No one is monitoring antibiotic prescriptions. And I mean, maybe we're here then. Maybe we are at the point where our public health threat of antimicrobial resistance has finally made us realize, well, there are people locked in jail or incarcerated in jail, and they are not necessarily receiving the benefits of antimicrobial stewardship. And they are worthy too. And just as an interesting tidbit, one of our research assistants, Emily Gussing, who is a fourth-year medical student, was sitting in my office. Another research assistant, Yvonne Gassa, was interviewing someone, an older woman. And her husband was sitting outside the office. And the husband, an 80-year-old man, said to her, "What are you doing?" She said, "Oh, I'm trying to improve antimicrobial stewardship in jails." Said, "What is that?" And I appreciate that man's views, because some people don't have, like, just, have that blockade, and they wouldn't know to say that. But how incredible that we had that experience. What a waste of time, the person said. Now, thankfully, she was able to bring him forward. So actually, it's not a waste of time. We can save money. We can, if it only comes down to money, that interaction that occurred was like, okay, this is stuff that needs to be done. If someone thinks it's a waste of time to include antibiotic care in jails, then this is something that needs to be done. So we have leaders of antimicrobial stewardship in our audience today, and I just want to show you that if you PubMed this, there's no antimicrobial stewardship. And I granted there could be different perturbations, but there's none. There are two in prison. One was from South Africa, and one was published in 2000. I don't know. I think it was in, I can't tell. Yeah, 2017. I don't know why it says 2000. And that was the Federal Bureau of Prisons. Now, I'm not talking about prison. I'm talking about jails. Now, in contrast, if you look at antimicrobial stewardship program nursing home, there are 89 results. And if you just look up antimicrobial stewardship program in general, there's 35. So obviously there's a gap, right? We haven't made it there. So bringing it back, what we know is antibiotic stewardship programs decrease the costs, the side effects of antibiotics, and they're just overall recommended for several reasons. That's why we invest in that. But antibiotic stewardship programs are not routine. Now, I'm not saying there might be one jail out there that has one, but I'll tell you that Massachusetts doesn't. You don't have it in the jails. You can spit and hit an ID doctor in Massachusetts. Okay, I don't recommend you do. It might spread things, but I'm just saying there's a lot of ID doctors here, and we don't have them in jails. So here's my experience and familiar there. So propelled forward by clinical interactions. I worked with pharmacists at the State Office of Pharmacy to get a database of all antibiotics prescribed in Massachusetts jails. All of the jails get their antibiotics from one place. And this is 11 jails, and it's the antibiotic name, dose, length of treatment, and prescriber. It was granted as non-human subjects research. And I worked with our group here, including Gabriella and Sheer and Maureen. We decided to calculate the defined daily dose for the average daily population. I had never heard about the defined daily dose. It's a big thing. I think Europe uses it more than we do. And basically, you calculate how much of a dose you would give to someone, and then the defined daily dose as determined by the WHO, and then you basically divide it by your population of interest. So you can divide it by, let's say, how many people are in the hospital. This is one of the hardest parts about doing jail research, because I can never know how many people are in jail. Fortunately, with COVID, there was actually this thing that came out where they reported weekly how many people were incarcerated in jail, because, and it was like a tracker, and because there was lots of decarceration. So that's what the defined daily dose is. So here is the research. It's going to be presented at ID Week. It's Bart, who is an MBS MPH student. Tara, who's an ID fellow, has been working on it. And we submitted to Infection Control and Hospital Epidemiology Journal. I guess what I want you to take away from here is heterogeneity. These are normalized by the population in jail. So in jail 1, there's not a lot of antibiotics being given. In jail 2, there are a lot of antibiotics being given. And at this point, I don't know why. I don't know why one place is giving more. It's hard to say. These are all jails. I don't think people have older people. I don't think we have different populations. It's likely because of the prescriber, and what the prescriber and the clinicians, and whether or not it's actually given out to everyone. So I felt like, okay, now I'm reinforced. I'm onto something. And so let's move forward. Because we know that standardization improves healthcare. And heterogeneity is a signal that there needs to be more standardization. And I don't want you to take this to be like, I believe in the melting pot and all people should look the same and all people should act the same. I'm not saying this heterogeneity is a bad thing. Diversity, we know, is a beautiful thing. What I'm saying is we know that checklists, surgical checklists improve outcomes because they standardize things, just like aviation has been revolutionized with checklists. So guidelines and checklists help. And I know this because I've been doing work even before this process with antimicrobial stewardship, looking at the intake forms in Massachusetts jails. So A, B, C, D, all across our different jails, and going down is whether or not on their intake form, the only mandated interaction between someone in jail and a clinician is at intake. Other interactions can be refused. That is our only opportunity in theory to offer these things. And you can see that not everyone offered Hep C testing, not everyone offered HIV testing. No one asked about PrEP, whether they were on it or whether they should be on it. So this is a sign of heterogeneity within our tiny little state of Massachusetts. Then this is flu vaccination rates. This is before the COVID vaccine was approved. Tried really hard to get in the jails and get flu vaccines. And this is the flu vaccine acceptance rate at different jails. Again, you've seen heterogeneity. And I mean, there are political differences and socioeconomic differences across our tiny little state. But I don't know why one jail would have a 15.9% acceptance rate, meaning someone was asked if they wanted the flu vaccine and said no, versus one would have 50%. Overall, it's pretty low flu vaccine acceptance rate, I would also say. So heterogeneity exists and is an opportunity for us to find out, well, why is this heterogeneous and how can we improve? And as CDC actually came out explicitly to address the heterogeneity in April, where they actually gave guidelines. So they saw what I was seeing too, and they said, okay, well, HIV should be tested. All persons should be tested for HIV. All persons should be tested for hepatitis B, and they gave guidelines. And once you have guidelines, you can say, oh, I have guidelines. Are we doing the guidelines? Is there a possibility something bad could happen if we don't do the guidelines? And that really, guidelines is one of the things that really gets people. Okay. So I'm going to talk about the fabrics. Fighting antimicrobial resistance in carceral settings. I feel like studies need good names. The cardiologists and the neurologists are onto this, I think, before us. I'm married to a neurologist, and, you know, like, so they really get these really cool names. I guess for the HIV studies, they have that. But this is our team, and these are the states. I know some people may argue that not all of them are New England. I'm from Connecticut. I do feel like a New Englander, although I guess they're like a nutmegger or something. I had, we just had our first meeting, representatives, jails, academics, from all of the states there. If I can tell you, this was such an achievement to get people to even come to the table to say, let's talk about prison antibiotics in jails, just to get them even to come to our kickoff. So they were all there. It was a wonderful meeting. It just happened. So what are the aims of this study? The first aim is to identify patient, clinician, and institutional factors associated with increased prescribing of antibiotics and broad spectrum antibiotics, meaning in jails and prisons. So that's the quantitative aim. And then the qualitative aim is to understand perspectives of key stakeholders and barriers and facilitators to implementation of antimicrobial stewardship programs in New England. So just to get it in our heads, it's two aims. I love mixed methods or multi-method study. They really help you understand. The quant can help you understand the qual. The qual can help you understand the quant. So we have two aims for our study. So where we are right now is quantitative aid. So we need to get the data set. So we received IRB approval for G-identified patient level data for all the Massachusetts prisons and jails on type of antibiotic, dose, length, demographics of the person incarcerated, and allergies. This is actually really exciting for me because I'm really interested to see what's happening about, I see a lot of people with penicillin allergies, and I actually think it's more prevalent in people who are incarcerated. And so just purely showing how many people are in jail and prison who reported penicillin allergy is going to be a really interesting thing. But I'm waiting for the data because I need further approval from the Massachusetts Institution. It's been like a 2-month process just to get this. And we're meeting scheduled to talk about data acquisition. So what are we going to do once we get the data? We are going to calculate the GDP for each jail and prison. And then we're going to calculate these things called HEDIS measures. They're healthcare effectiveness data information set. I had never heard about it. It's through CMS. And for an example of a HEDIS measure would be average days supplied per antibiotic per person per day. So hopefully we'll be a little bit more granular and we're able to define numbers. Then we're going to do univariate and multivariable regression. The primary outcomes of interest being days of antibiotics, exposure to broad antibiotic, and the variables being age, race, ethnicity, prison and jail. My hypothesis is obviously older people will be more likely to be exposed to more antibiotics. And I don't really have a hypothesis yet about race. But I wanted to backstep and talk a little bit about race in terms of our jails. So, you know, I would say about 12% of people in the jail population in Massachusetts are Black, about 25% of people are and so, whereas in places like Rikers Island or even in the South, the prisons are 80, 90% Black. It's a little bit different, but it's still way more given the disparate between populations. So that's true for Hispanic population, that's true for Native American population, for Hispanic and Black population as well. So just an interesting thing, and also interesting, another way in which sometimes as a Massachusetts jail doctor, other places don't necessarily believe in generalizability because the actual racial composition of the jails does not look like the racial composition of the jails. Okay, so qualitative aim. Now moving to the qualitative aim, and this is going to be sort of done a little bit of a scoping review, looking for what is out there, people asking others about, what do you think about antimicrobial stewardship programs? And then we develop the interview guide. So we've done those two things. And now I'm going to talk to you about choosing a framework. And I feel like if you say the word framework, people like want to run out the door because the word framework is very scary and it means this is inaccessible. This is a framework. This is a fancy term, but I don't want you to think about that as inaccessible. In fact, I really want you to think about how, in my research, how can I bring a framework? I want to do a PI project. Maybe I can use a framework. It'll increase the likelihood of it being published because now it's not just about doing PI projects. You really should have a framework for how to do the PI project. So this is the CIMAR framework. I'm not going to explain it all to you, but there's basically these 5 domains: outer setting, inner setting, characteristic of individuals, process, and intervention characteristics. And those are the ways that we think about all the things that can stop us from providing evidence-based care. Is it the structural characteristics of the actual building that prevents us? Is it the complexity of the design? One thing that was coming up with vaccines, just as an example of let's say complexity, like vaccines are evidence-based interventions. But depending on how many doses you have in the vaccine and the process and the packaging of the vaccine bottle and how many vaccines you can withdraw, there was like a complexity around the actual process of delivering the vaccine that was interrupting our ability. So just give an example of that. So those are the contextual factors. What are all the different things? And then the next one is this thing called the theoretic domains framework. Those are the individual factors. How much about someone not prescribing, deciding to prescribe 5 antibiotics, with 5 days of antibiotics, which is 14 days of antibiotics, is about their knowledge, about their memory or attention to learning about something, about emotions around antibiotics. Well, I don't want to prescribe too little because if this person who's incarcerated then gets sick, now I have these are the things we need to start getting at. What are the emotions involved with prescribing? I feel that emotion as a prescriber. When I prescribe less and less and less and less, I start being scared. I start feeling like maybe this person's going to get sick. Because it would make me feel better if it was longer. But then you don't really think about the emotions on the side of what about the content. So we're preparing these interview guides. We've developed them both for the carceral setting. So we're going to interview people who are incarcerated. So we'll be doing that at Norfolk County Jail. We're going to be interviewing clinicians, so prescribers and nurses in the jails, corrections officers, even saying to me, why are you interviewing the corrections officers? And the reason is they are an integral part to how the jail and prison functions. If a corrections officer says, I got the vaccine, you should benefit, it means a lot. And there were corrections officers who were championing vaccines in jails. If a corrections officer is talking and says, you know what, never get that, that means a lot. So the attitudes and the perceptions about antibiotics and about taking antibiotics and about healthcare in general, we need to get them right. And then stakeholders in the community. So I may be asking some of you actually to say, what do you think goes on in jail for antibiotics prescribing? Do you think it could be improved? Do you have any experiences about that? So those are sort of all the different opinions that we're going to get and try to understand. Here's an example of the interview guide that we're going to be doing. So this is, we've already piloted it. So to what extent do you advise patients on the risks and benefits of antibiotics? So that's just an example of a question that we asked patients. Has there ever been a time when you did not think antibiotics would be warranted? We all have been through that time. It's easier for me to say no to a patient on the outside of jail than it is for a patient. It's so much harder for me to say no to antibiotics. Like I'm trying to put a patch on that structural, determinants of health with my antibiotics. You want this. You've been through a lot. I should give you this. But then, then if you step back, you're like, well, maybe I'm causing harm. And then here are some examples of questions that we're going to ask of people who are incarcerated. Like what it's like to be incarcerated. We've already done this with people who are incarcerated. It is actually, you can kind of imagine some of the answers that we get. If someone had a question about antibiotics, who would they ask? I've had people who've been on antibiotics every day. Remember, they don't have it. They go to the nursing cart every morning at 5 a.m. and the nurse gives it to them. Yeah, I've been on this for like a long time. I don't know why. I don't know why I'm taking it. But who would you ask that question to? Has that ever been a situation? Can you refuse the antibiotic? And if the nurse says, oh, it's time for your antibiotic, and you say, well, I already finished 10 days of it. I don't know both time for your antibiotic. The correctional administrative staff, which is a term that I'm sort of thinking about, the administrators, the sheriff, the superintendent, the corrections officers. Did you receive any training about health procedures, antibiotic prescribing? And then nurses, what kind of require antibiotics? On a scale of 1 to 10, how comfortable do you feel dispensing antibiotics? And you all may say to me, well, that's numbers, that's not a qualitative answer. But I love this question because it actually says, let's describe the answer. These are the best questions because you get them because they just, and why do you feel that way? Okay, so you may say, why are you doing all these interviews? Interviews identify key themes which can be mapped into strategies that can guide interventions. And as you're thinking about your project, don't reinvent the wheel. There are websites where you put in what you think the problems are, and it will tell you what the answers are. People have done this already, and we don't need to reinvent the wheel. So, for example, if clinicians say there's no system in jail for monitoring lengths of antibiotics, and a strategy, this is a really good reference. It's called Geographic project. So a strategy. There are 73 strategies, the actual strategy. Think of it like genes. Like, this is the strategy. This is your way to change things. Identify and prepare champions. It's my favorite strategy because I feel like champions are the way to really make change. And so the operationalization of the strategy would be expand the scope of the jail and pharmacist to include monitoring of antibiotics. That is not part of their role right now. And there will probably need to be a discussion about, well, we need to get another pharmacist because there's too much, but then is the money that spent on the extra pharmacist would be worth all the money saved from the nursing time administering Clindamycin 4 times a day, or for the hospitalizations related to the negative outcomes of. So just to update you, this is our goals right now, and we're leading towards an R01 submission. My work here is funded by the Tufts Medical Center. I am so grateful for these grants, and I need to springboard into other funding. I mean, that's the whole purpose of this, to springboard. So the R01 submission hopefully will be in June 2023. And hopefully what we're going to do with all these ideas is come up with a strategy that works and describe to the NIH how we're going to make it happen, what our outcomes are going to be, and really just it would be a 5-year project. So that's my goal. So I'm just going to say we've hit barriers. And if I feel like sometimes people talk about the research and they don't acknowledge the barriers. As someone working to do research in incarcerated populations, IRB submission is such a challenge. And there are, and I understand and appreciate the history of unethical research, but it is a really, really hard experience to go through. And then have to build trust with the first role leadership. There have been so many times when people have tried to put watchwords on the jails and prisons, especially as it relates to COVID. You didn't do this right. I have been accused personally of doing a crappy job of COVID. You know, so there are people that feel, and if you, I believe in incarceration. I feel that too many people are in jail. But I also believe that my job is to improve the healthcare for people who are in jail. But I've had to pull the sheriffs, everyone over to my side to build trust. And that's happened. I've been doing this probably for about 7 years now. And I only started really over trust. And then there's the limits of the data set. So the data set I'm going to have is not going to have anything about the communications. And that's a huge limitation. But unlike the hospital admission set, basically a jail has something called the offender management system, which is when did they come in, when did they come out, the electronic medical record, and then the pharmacy record. And so there are 2 different data sets. And I just went for the one that was really easiest. So in conclusion, I just feel like whenever someone says in conclusion, I talk, you can start suddenly being able to breathe again and think about all the other things. We are getting closer to the ultimate goal, which is bridging the gap between what we know and what we practice. I'm very proud of myself for doing that. And the ultimate goal is to implement antibiotics. I am so lucky. I have this huge team, and some of them are here, Yvonne and Vidve, so thank you for coming, and I see Tara there. And I am just so thankful for this team. I love the metrics moving forward. Rebecca Tenner, who I think is online, it is the second from the right, CIMAR award this summer for to do this research. She is the one who's with Emily Resting, who's a medical student, has been pushing forward. Thank you to my mentors, the Mass Sheriff's Association, and may the sports be with you. Like, let's collaborate if you have ideas, especially around antimicrobial use. Yeah.
Invite people to put their questions into the chat while you're, and then when you look at them, you can repeat them for the audience here. And I'm just going to ask you a question about, kind of the issue of prescribing antibiotics in the jails and the lack of the ability to actually follow up. So we feel a lot more comfortable prescribing a shorter course if we know that we're going to have follow-up. So is the limitation sometimes with maybe erring on the side of caution, the fact that you're not sure you're going to be able to get back to follow-up?
It'd be more that basically the person who had, I only go to the jails once a month. And so it would be more that the person who I'm seeing that day with the cellulitis, at bedside is not better. And so it's less that they're going to be discharged into the world.
But you're not going to be able to see that.
Not right.
Because,
well, they may ask me to see, but yeah,
but you're not the one being able to see them erring on the side of caution.
Yeah. I think it is. It's also interesting when you think about some of the things that we think about as food infections in terms of soap and hygiene and access to soap and access to wanting to be able to take a shower, things like that that when you think about as regular parts of our hygiene to fight infections. I just feel like it's very different in the jail. Whether they're being charged for soap or they're being charged toothpaste, which we know is happening.
Debbie?
That was great, Alysse. So having worked in the prison system and with Celeste, I wonder how you anticipate the corrections officers being willing to participate, not necessarily their answers, but the participation.
Well, Vaughn did some surveys with the corrections officers recently, and with a $50 Home Depot card, there was no shortage, honestly. And I think they do actually. Okay, that's fine. So we have never had a problem. As the corrections unions go, sometimes there are stipulations in the union contracts, which we have to go through the union to get approval. And that's but the actual interacting with the officers has actually always been well. One.
Great, thank you.
I had a question about if you have seen any barriers in terms of diagnostic testing and that aspect of informing, like figuring out what organisms, what is going on with people who have these infections and not informing antibiotic stewardship and,
Absolutely. Yeah. I mean, yes. So the diagnostic, other than a strep teacher, I think the average clinician in jail would not be swabbing us to see exactly what's causing this. I think if it's a urinary tract infection, then we feel like we have the appropriate diagnostics. But also interestingly, who are incarcerated, and then it's actually not antimicrobial for women and sort of the UTIs. Yes, the diagnosis, the actual culture is hard. But when I think about the spots that I want to intervene on, sinusitis and the viral sinusitis, the viral pneumonia. Like when I think about where the most antibiotics are unnecessary is ear infections and antibiotic. It's less about the purulent cellulitis. Okay, part of me is okay with 10 days of antibiotics for the purulent cellulitis. It's the 14 days of moxifloxacin for the viral. In which case, it's not often that we actually have the diagnostic ability even as an outcome. So it's more of those ones that I wish I could impact.
That's an area for each of the jails. Is that local, or is it if it's local, can you now start trying to correlate geography and local wealth, demographic factors of the community with practices?
So jails usually incarcerate the person who crime in the area. So it's not necessarily where the and often people see that close to home. And I do think you look at this is being recorded, but there are certain parts of the state which are wealthier than others, and I can imagine in those places, actually the oversight of the antibiotic use is in Western Massachusetts, it's from local, but in Eastern Massachusetts, it's through a corporation. So I don't think it's actually, if there's like a lot of moving factors there, the amount of money the jail gets from the state could be really interesting. And there are some jails that have negotiated a lot of money for health care. Now, Camden County and Springfield is one that historically has negotiated a lot of money for health care, whereas other jails, like Essex County, have had conversations way less money. So I'm not sure how, but I think it could be done. In doing that, though, one of the things I've heard about COVID is that each of the jails wants to be seen as its own entity. And when you start, I am comparing them to antibiotics, but they're also a little bit worried about that, because then it can make you feel like doing as much job when there's tons of outside reasons why maybe one jail has more flu vaccines than others. So it is also interesting thinking about places that are for-profit healthcare versus non-for-profit healthcare. None of our jails, like you can have for-profit jails. None of our jails in Massachusetts are for-profit, but the healthcare is for-profit. And at least in Massachusetts. One may think that if it's for-profit, then they would look better on using less antibiotics so they could save money. But I'm not actually sure looking at all the different types of deals.
So Alysse, on your demographics, will you have their zip code from where they came? Oh, that's too bad, because that could get at John's question.
Through a zip code, you can get a social vulnerability index that can give you an idea of the sort of financial health of the place that they came from.
I think you can calculate, you can bring in a social vulnerability index, actually even up to higher census regions. I wonder to be even at the county. But as we're here, I want to throw out an idea. So in Cook County Jail, what they did is they started doing breakfast clubs with everyone before they went into jail, and then sequentially through their jail stay. And since they have such a high use of clindamycin, topical clindamycin, they actually found the microbiome change with clindamycin throughout their incarceration stay. And you know, the whole I love that idea. I mean, I love that idea of microbiome, who has what disease and in jails. Just to think about, I don't, you know, me myself, I don't have the money or the staff, but you know, thinking about where we can work together. And then the other thought being, MRSA rates are going down. It seems like nationally. Yet incarceration and poverty is something linked to MRSA. And so people are getting overly broad anti-MRSA antibiotics. The MRSA that existed 10 to 20 years ago, and that's especially true in jails. And so to understand how many people are actually colonized with MRSA in jails would actually also be really interesting, because I don't think it does much as it used. We don't have where it started, but my understanding is it's going down, and I don't know why it needs to go down. Who's effective in the jails and stuff. Another interesting question that came up on a big point that came up, actually, I think Shira, we were in phone call. None of the directors of these jails and prisons had ever seen a C. diff, which is odd. I mean, so I was having this, you know, before bedtime conversation with my husband, who's also a doctor. Because on the call, I was like, well, maybe it's the microbiome. It's dirty in prison. So like, you know, like that fights off the C. diff or something. He's like, maybe people are just like suffering through C. diff and like not telling anyone, and they're just not getting, they're just not, like there has to be like a self-limited version of it or something. So I don't know why that is, but that was shocking. I've never been asked to see a patient with C. diff in the jail. I've never been told about it. And so to your question, is it about the diagnostics? You know, when someone has diarrhea, I think they're more likely to check for Shigella, which we found, all these other things which are public emergencies, you know, that cause them versus. So just giving some ideas that are really interesting. Yeah.
Sherry Gorbach would have told us that the treatment for C. diff, sorry.
So our revered colleague, Sherry Gorbach, who was one of the discoverers of C. diff, at one point, the treatment for C. diff was stopping antibiotics. So yes, I think there's probably been C. diff.
Yeah.
Well, that was a fantastic talk. Thank you so much. And I think we're at the hour, but we're available. So there might be some other questions. Thanks everybody for coming.
Yes, I think we got something.